So my name is Jay Seth. I'm a consultant urological surgeon or a urology consultant. I have a special interest in bladder and pelvic floor disorders such as urinary incontinence, urinary symptoms, urinary infections in women and men. I work in London. I work within the NHS, and I also work at the Chelsea Bridge Clinic in London, which is where we've started the London Bladder.
Okay, thank you, Jay. Could you please give us just a basic description of what does incontinence actually mean?
Yeah, absolutely. So urinary incontinence tends to describe involuntary leakage of urine. So when someone has loss of urine, either during an activity or in an unpredictable manner, loss of urine involuntarily would be described as urinary incontinence. Fecal incontinence, the same thing applies to the loss of feces. And so urinary incontinence applies to the loss of urine. And that's an involuntary process, and it can vary in degrees according to each individual patient. It can be, generally the subcategories can generally be well classified into mild, moderate, and severe. But involuntary loss of urine, which is different to voiding. Voiding is, the controlled planned process, the organized process of finding a toilet and taking a wee. So voiding is a planned behavior, it's a learned behavior. And so in infanthood, that's akin to involuntary loss because we're reflex emptying our bladder, but we learn voiding during our early years. And that process is quite a sophisticated mechanism that, for a whole range of reasons, can be interrupted, and then that leads to loss of urine.
You said that there are different degrees of incontinence. So presumably that means just happening just occasionally or a small amount through to sort of a full bladder almost. Could you talk about that, sort of the different degrees and levels of incontinence?
Yeah, absolutely. So, there's different types of incontinence and there's different degrees of incontinence. Some people may describe very light urine loss that can be managed by wearing a thin liner, and you may have a pad that's slightly damp, and it's a nuisance, it's annoying, but again, people may find that they can manage it or control it, especially if they can find that it's a predictable type of incontinence. If it's unpredictable, then it tends to become a bit harder to try and accommodate and plan your day around. The other end of the spectrum, severe loss of urine would then the patients people may describe leaking large volumes several times a day into pads, which then lead to heavy pads. That can happen daytime, it can happen afternoon, early evening, it can happen at night, it can also happen during sleep and issues with bedwetting. And patients may then be changing multiple pads a day, and they may be quite heavy. They may be quite heavily sodden or heavily soaked, and that would be the more severe end of the spectrum. So you've got a light end of the spectrum where you may leak one or two drops and manage to secure that through one thin liner a day, several pads a day, which need to be changed every hour or two, and they can be heavily soaked or sodden. And that's probably the more severe end of the spectrum.
Okay, thank you. And you said there are different types of incontinence. Could you talk us through those?
Yes, sure. So the most common types of incontinence that we see are either overactive bladder, leading to urge urinary incontinence, or stress urinary incontinence. Now, overactive bladder tends to be a syndrome where people may describe leaking urine without much warning. They get an urgent feeling that they need to pass urine, and they can't ignore that, and they're desperately looking for a toilet. They may be weeing very frequently. I think the important thing is that there's not so much warning, and it's very unpredictable, and it can happen day or night. And there's generally a preceding signal of urgency, which comes with desperation that they've got to find a toilet. Otherwise, they may have an episode of urge incontinence, which is when they can't get to the toilet in time. Some people also describe this latchkey phenomenon where they are desperately looking for a toilet. They're managing to hold on, but as soon as they get close to a toilet or put a key through the door, then they lose control. That's urge incontinence. Stress incontinence contrary to what it sounds like, because a lot of people may feel stress incontinence is related to anxiety or psychological stress. The way stress incontinence was originally described was related to physical stress. So that's a bit more predictable. This is down to largely a weak sphincter or a weak pelvic floor. And it's a bit more predictable because I'm going to leak when I run. I'm going to leak when I cough. I'm going to leak when I trampoline or jump or lift heavy groceries or play golf. And then that can lead to avoidance behaviors because you avoid those behaviors where you know you're going to predictably leak as a result. So that's stress urinary incontinence, so physical exertion leading to incontinence and common activities, as we've mentioned, coughing, sneezing, laughing, dancing, trampolining, bending over, lifting groceries, swinging a golf club, that kind of activity.
Okay, thanks. So is a postpartum woman more likely to have one or other of those types, or could either manifest?
Yes, so it's a good question. One thing to comment is that you've got urge incontinence from overactive bladder. You've got stress urinary incontinence from a weak external urethral sphincter. And then there's this complex of mixed urinary incontinence. So a lot of women may have a combination of the two. And it's important to delineate that because the management of both of those complexes is slightly different. And sometimes you need to target both aspects because there's no one treatment that generally cures everything. But mixed urinary incontinence is probably what a lot of people describe, where they feel that they're going very frequently. They may not be able to hold on to their urgency, but they also have leakage with exertion.
And so where does a hypertonic pelvic floor fit into that? You described the stress incontinence as weak urethral sphincter. How do we understand when we're told we have a hypertonic pelvic floor?
Yes, so the hypertonic pelvic floor is interesting because we have this increasing understanding that a lot of people, particularly younger people, have issues voiding. Presents as a bladder problem, but it's actually a pelvic floor issue where there's for some reason or another, whether it's hormonal, whether it's a learned behavior, whether it's anxiety related, but the pelvic floor relaxation process becomes less effective. And as a result of a high tone pelvic floor or a high tone urethral sphincter, if you imagine, it's a bit crude, but if you imagine weeing out of some little orifice, your pelvic floor really needs to contract to allow you to pass urine through a much bigger channel. That relaxation process is a muscular phenomenon, and that for some people who have a very high tone pelvic floor or high tone external sphincter are unable to relax their pelvic floor to allow the urine out. And as a result, their bladder may respond in an irritable way. It may make them more urgent, more frequent. They may not empty their bladder completely. They may get urinary infections as a result. And so sometimes it is just working, on the pelvic floor with a specialist to kind of really try and down-regulate the inhibitory pelvic floor, which is just not allowing them to empty their bladder. And when you go on to do slightly more sophisticated testing, you look at what we call the flow rate, which is the speed of flow. So the speed of flow, when you measure it in someone with a healthy system, you'd expect a very fast wee. That ends quite quickly. Whereas someone with a high tone pelvic floor, it may be a very prolonged wee that goes on and on and on. It's very slow in terms of its speed. It may be intermittent. It may be stopping and starting. And you can see that they're really trying to also push with their abdominal muscles to push the urine out, where they should be really focused on relaxing the pelvic floor.
So what types of incontinence and what kinds of conditions can pelvic floor exercise really help with this, Jay? And when might exercise not be enough and a patient might need more medical intervention?
So, for example, if we take stress incontinence, having a pelvic floor assessment is an important part of the evaluation process, particularly if it's postpartum and the pelvic floor is weak. And there is work to do there with regards to deficiencies in the pelvic floor muscle, its strengthening, its contractile strength, and getting that stronger. And clearly a lot can be achieved with some focused physiotherapy or some pelvic floor strengthening. And with regards to weight loss as well, we know that if you have someone who is in the obese category, or certainly with a BMI of over 30, and we see patients with BMIs of over 30, over 35, and getting them to lose weight, we know then takes some kind of load off the system, allows them to work on their pelvic floors, takes pressure, if you like, off the bladder, the physical pressure off the bladder itself, and can really help with bladder symptoms. But it can become a little bit of a vicious cycle, because they may say, well, look, I can't run, I can't exercise, because if I exercise, I leak. So how do you expect me to exercise and lose weight? And then clearly there's going to have to be a dietary component as well to winning that battle. But weight loss, particularly if you have a BMI of over 30, or especially over 35, trying to get that down into a 25 to 30 category as a start should help. But clearly someone who has then achieved pelvic floor strengthening and their pelvic floor system has gone from a 1 out of 5 or a 2 out of 5 to a 4 or 5 out of 5, and they've done their bit, they've strengthened their pelvic floor, they may have achieved some weight loss. If you've got someone who's still wetting into liners or pads, or having to change pads regularly, that's quite distressing. It can really have several knock-on effects in their life in general, in terms of their confidence psychologically, and then what they restrict themselves doing. So if they've tried the first and second line of weight loss and pelvic floor strengthening, then we would tend to talk to them about the other options, whether they're medical options or injectable options or surgical options, to try and give them more control. And that would be the time to do that, as opposed to getting them to continue doing repeated pelvic floor strengthening, and because that will then just get disheartening for them.
Absolutely. Yeah. If it's not working, we need to try something else, right? Yeah. Why are you comfortable recommending or referring your patients to Muti system where that's appropriate?
So I think it's really important, especially when you have a situation where the health services are so overburdened, as patients taking some responsibility and autonomy, and not just waiting for someone who is not going to be available for many, many months, and increasing access in a remote manner, in a virtual manner, to any form of self-help, such as the Muti system, I think really gives the patient autonomy. It gives them a structure. It gives them some kind of strategy over a period of time on how to achieve small goals, and I suppose it's those achievable small steps and persistence with that to achieve the ultimate goal of trying to restore strength and control. And also knowledge of the Muti system would allow the patient or person or client autonomy, instead of waiting and just prolonging their own suffering.